kind of joined together, and we have our medial and our lateral lobes
This
of the
meeting is
suspensory.
being recorded.
And this vascular structure here is kind of an important landmark for when we start talking about doing our ultrasound of that suspensory ligament, because that's when we can really assess both the medial and lateral lobes well on ultrasound. Innervation of this structure is from the deep branch of the palmar ramus of the ulnar nerve. So that's important when we're doing diagnostic anesthesia. Obviously, you can do direct blocks, direct ultrasound guided blocks here at the origin of the suspensory ligament, um, or you can do a more proximal block of the ulnar nerve or median ulnar nerve to get full anesthesia of this area. Hind limb, fairly similar. So again, we said plantar cortex of MT3 in this case. But we also have some contribution from the distal plantar ligament. So in some references, I think Dyson, she calls it the accessory ligament of the suspensory ligament. But same structure. This is just the nomenclature that Denois prefers here is the distal plantar ligament. That distal plantar ligament is also has some fibers conjoining with the long plantar ligament. So in some ways, these three structures are blended together to all contribute to the proximal suspensory, or suspensory ligament in general at its proximal aspect. Innervation of this structure on the hind limbs from the deep branch of the lateral plantar nerve, which itself is a branch of the tibial nerve. So again, important to consider when we're um, thinking about doing diagnostic anesthesia blocking when we're working cases out. One of the reasons why I point out these other structures, these involved insertions, other than just kind of what we think about what we're taught in school being that plantar cortex of the cannon bone, is all these structures can absolutely play a part in some of the pathology we see in some cases. Um, a lot of these things are difficult to diagnose on, just with ultrasound, but it's certainly possible. But just something to take into consideration that when we have injuries to either the forelimb proximal suspensory ligament or the hind limb proximal, we can certainly see involvement of some of these other insertions and attachments. Uh, Brief little bit on the biomechanics. Fairly simple, not an easy job that it does, but a fairly simple job. And that it supports fetlock extension in the reception, loading, and stance phase. So it'll work in conjunction with the flexor tendinous units to support the distal limb as the horse is weight bearing. Then also part of the stay apparatus for passive suspension of the limb. For clinical cases, we're going to start out with a 5-year-old warm blood gelding. It's used for show jumping. Presented for evaluation and rehab here at Epic back in October of last year. History was kind of sketchy. Had been seen by the trainer's vet, treated, then just turned out. The owner felt as if the injury was getting worse with turnout. They couldn't get any of the records or images or anything. So came to us for kind of just a fresh evaluation.
Just click on it.
So this is him. As you can see, not very exciting at a walk. Pretty good symmetry. He's interested in what's going on around him.
I'll minimize that. Click on the mind. And it's one.
He was kind of dragging Camille all around. So nothing super exciting here at a trot on the circle other than the horse himself. Um, get him to draw some decent circles here. Not an extremely helpful exam. Here. So we see a few kind of intermittent off steps on that right front, specifically in that right circle. Um, mild grade 1 to potentially 2 if you want to get really picky. Right front lameness is what I call it. And again, we did have somewhat of a limited dynamic exam just because he wasn't entirely cooperative and he was getting ready to start flying like a kite if we kept going too much. Palpation, this is just kind of summaries of some of the significant findings. Right front lateral and medial suspensory branch were reactive or sore on palpation with some pretty significant thickening at the lateral suspensory branch. Mild to moderate positive on lower limb flexion on that limb. Left front full limb palpation was negative. Part of the history I did get on this horse before with the previous veterinarian was that they did block and he did block to a low 4 on that right front. So I was fairly confident that we're still dealing with that same issue. So we just jumped right to diagnostics on him. These are some images from that right front lateral branch. Start over here on the left one. We can see some nice fissures, kind of almost dissecting or bisecting the superficial aspect of the suspensory branch here. We can see that there's a bit of periligamentous fibrosis as well, some fluid or edema in the kind of structure of this branch here. As we continue down a little bit further distal, we can see a couple little pockets where there's actually some hypoechogenic core lesions, and we still have those kind of fissure lines there. And then distal towards the proximal aspect or apical aspect of the sesamoid, we start to get a little bit more normal fiber pattern, but we can still see that there's a little bit of periligamentous fibrosis here, not bad. And a little kind of persistence of this core lesion, probably the same, just the distal extent of what we're seeing here. Long axis, the actual insertion at the sesamoid wasn't terribly abnormal, but we can see this clear disruption of fiber pattern in this more kind of superficial 40, 50, 60% of the ligament that represents what we're seeing through here. Looking at the medial suspensory branch, we have some similar findings, kind of a little bit less distinct tears, less distinct fissures, less distinct hyperechoic regions, but we still certainly have some, or hypoechoic rather, but we certainly still have some hypoechoic regions here, maybe even a little bit more periligamentous fibrosis on the medial branch in this case. And then some pretty clear disruption of that'd be the dorsal border of the branch here. So kind of just synthesis on that is we have, I guess, biaxial right front suspensory branch desmitis. Really not a whole lot of insertional component. Again, I'd characterize that as being relatively normal given the amount of damage that we have in the ligament itself. So mostly a suspensory branch desmitis without a lot of enthesopathy involvement. Treatment for him, initially we started with therapeutic shoeing, which we'll get into that a little bit here down the road. He was at Epic, so we did have some good options as far as therapy. So we put him on the vibration plate. Initially had him in the spa, hand walking, magna waving that fetlock. And then after he was here for a little while longer, we were able to get approval to do another Renovo treatment. That's part of the history I left off, is he did receive a Renovo. Timeline was again not very clear, but it had been a month or 2 months or so prior to when I treated him. So we did Renovo in that right front suspensory branch, the lateral branch. I focused on that lateral branch, put a CC in some of those core lesions, a CC around the ligament, and then a CC in that fetlock. I figured that the kind of local treatment of treating the fetlock would also help with that, the changes that we're seeing on that medial branch, even if we're not treating it directly. And then we also got approval for shockwave. So we started doing 1,000 pulses on both right front branches. And then I didn't show the images here, but he had some very mild marginal changes on the left front medial branch. So I included that in the shockwave treatment as well. Therapeutic shoeing, this is the shoe package that we decided to go with. So you can see that we have relative increased surface area at the toe here with relative decreased surface area at the heel. You can see on these other still images here that this horse is trying to get pretty underrun on the heel, especially on this right front. So even though we're decreasing heel support with this asymmetric shoe as far as the loading goes, on this kind of horse, I still want to have pretty good heel support as far as fitting that horse as full as you can and trying to bring that heel support back as we're narrowing it. So just kind of trying to balance our biomechanics and optimize the shoeing on this horse. Quick little sketch I did as far as biomechanics of this particular shoe. Again, I was talking about the relative increased surface area that we see at the toe here from this enlarged toe plate. So that's what this little rectangle represents. Decreased surface area at the heels, so that's with this slightly smaller rectangle and slightly smaller, basically ground reactive force, however you want to think about it. Arrow here. And so what that's going to do is, we have three main structures that are supporting the fetlock: suspensory apparatus, deep digital flexor tendon, and superficial digital flexor tendon, which is not drawn in here. But this thin line represents the deep digital flexor tendon with its insertion down here on P3. So by having some relative increase in toe elevation while this horse is weight bearing, at least in deformable ground, right? That toe will kind of float. If you think on top of sand, that toe will kind of float on top of the sand a little bit, while that heel with relative decreased surface area will drop down a little bit. And again, we're shifting things in small percentages, but all we're doing that is loading that deep digital flexor tendon a little bit more as that toe comes up. This deep digital flexor tendon stretches. That stretching pushes, right, because it runs right back along the back of the fetlock here. That stretching pushes the fetlock forward, thus raises the fetlock, thus shifts some of that pressure away from the suspensory apparatus onto the deep digital flexor tendon. And again, with these shoeing packages, we're really only going to get those biomechanics in deformable ground. So just another thing to take into consideration when you're trying to figure out what kind of shoeing you want to do for particular injury. But I like these shoes quite a bit for pretty much any suspensory injury, as long as they have a healthy deep digital flexor tendon and you can do some work in deformable ground, then I think these are worthwhile. So this is a recheck. We're about 2 months, 2 months post presentation, a little bit less than that. So sound in a straight line. I don't have a video in a circle on this one. But overall looks pretty good there, minus the glare. And we did have improvement on both flexion and sensitivity to palpation. There was still some significant enlargement, especially at that right front lateral suspensory branch, but I mean, those those things tend to stay big, especially only being a month and a half or so out. So I was pretty happy with that. This is the recheck ultrasound. Um, so these top images here, those are right about that level where we saw that kind of distinct fissure line coming through here and here, almost taking a wedge of that suspensory branch out. And you can see that we can still see some remnant of that on the negative image at that same level. We can see that some of those fissure lines have filled in with a little bit of fibrous tissue. Um, so pretty happy with the healing there. I did note that we had some more fetlock effusion on these on this scan versus the previous scan. Just something to note, something that you could potentially add in as a supportive treatment would be some sort of joint treatment for this fetlock too, just some kind of regional anti-inflammatory, that Adequan or whatever you want to do there. And then again here we're looking at those same spots of anechoic or hypoechoic core lesions here a little bit further distal. But even those are starting to fill in just a little bit. We see that they're trying to do something. So this is, I think, the last recheck I have on him. No, we're focused on the right front suspensory branch on this horse just for this presentation, but we did mention a little bit on the left front. And as we went through our rehab protocol, he did end up injuring his left front lateral and medial suspensory branch as well, somehow doing something stupid in the paddock. Um, so we did go off a little bit on that left front. We did end up treating that left front, but we're just going to focus on the right front here. So overall, I was pretty happy with how he looked here. At this point, we are doing some flat work under saddle, mostly just walking with, I think we're maybe doing a couple few minutes of trotting here. Nice thing is this client had zero timeline. She was willing to take however long it went. So we really weren't working with any time constraints on this guy. Treatment that we'd continued here was periodic shockwave. We were doing it anywhere from every 3 weeks to weekly, kind of depending on the client's schedule. Continued with that same therapeutic shoeing package that we had, and then again, gradually progressive exercise. So at least those first few steps where he was trotting decently at right front distal inflection, really not bad. I will take that all day long for a horse who still has big fibrous branches. Um, this was the recheck that day. So again, we can see that we have some pretty good remodeling organization of that uh, suspensory branch. The size has come down some as some of that edema and some of those actual core lesions have resolved. Um, we can see some persistent core lesions there where we had some of our larger issues. We have some kind of persistent hypoechoic, just more um, generalized, irregular areas, but no distinct holes or anything in this part of that suspensory ligament. Um, Fiber pattern has improved. Definitely still not anywhere near 100%, but we do have a little bit more linear organization there than we did previously. So again, this will be we're about 9 months from presentation at this recheck. So overall, I was actually pretty darn happy with how this horse has been progressing. Um, Current update on him, still doing well under saddle. That little hiccup we had with the left front seems to also be healing well. So we're still slowly working back up to full work, but the goal is that we will get there on him. Doesn't have any fetlock drop. No other signs that this is progressing to a degenerative suspensory ligament desmitis. It really does seem like he just has bilateral forelimb suspensory branch injuries on all four of his branches at this point. So there's that, and you can kind of see in the videos watching him cruise around that he's potentially kind of hard on himself, especially when he does have even just limited turnout. So not that surprising that he's beating himself up a little bit as we're trying to get him to heal. See how
Month.
yeah. Move through this clinical case. 13-year-old quarter horse gelding used for barrel racing. Presented on May 27th of this year for soundness evaluation and farrier consult. I actually think this is one that Dr. Burnham referred into Epic that he'd seen. History was recently seen for a left front lameness, which resolved without any significant treatment after an abscess blew at the heel bulb. But they've been having some kind of continued difficulty shoeing, and the horse seemed to consistently be growing a long toe. This is kind of an interesting case. There's a few different things going on, so we'll get to go through this together. So maybe a little bit off in the hind end here too. Fairly stiff, a little bit of a fat horse. But we can see there's a decent right front lameness there. Let's watch him on the turf. So similar here, if maybe a touch worse. Seemed like he was a little bit more consistent, but pretty comparable between the hard ground and soft ground, in my opinion. So BCS was a little bit high, so a little bit fat. Moderate right front lameness. There was a mild decrease in the cranial phase on that right front as well, and he was definitely worse on the right circle. I didn't include those videos just for time's sake, but he was a little bit worse on the right circle on the softer ground. So that was consistent with that straight line that we saw where maybe he's a little bit more consistently off on the softer ground versus the harder ground. Negative to hoof testers. He did have an old lateral splint on that right front, quiet, no sensitivity to palpation, with some mild thickening of the proximal suspensory ligament, strong positive to a Churchill test on the proximal. Otherwise, flexions were insignificant. Decided to start with an abaxial nerve block on that right front. These will flip over, at least they did last night. So pretty decent improvement there. I liked it. I would call that a positive nerve block. Well,
They're gonna give you 30 minutes only.
oh, is it? Oh, I have another 10 minutes.
No, I mean the Zoom.
Oh,
Yeah, 10
10 minutes
minutes.
on the Zoom, yeah. So we'll get them going here in a second. So definitely still some right front lameness there present, but pretty improved. So I called that a positive nerve block. We were here to look at that foot anyways for a farrier consult, so we took some balance radiographs. He was towards the end of the cycle as far as shoe placement goes, being up underneath the center rotation of the coffin joint. I'm happy with the, 60-40 split at the end of the cycle. I think that's 100% reasonable. So I personally thought their farrier was doing a pretty good job. Maybe a very, very mild medial lateral imbalance, but we can see cannon bone's now perfectly straight here, so maybe that little bit of increase in length on that lateral aspect is positional. Either way, that's minimal. Here we do have a little bit of gas up in between the heel bulbs, or maybe in the heel itself. So we can't see it on the DP, but we can see that there's some suspicious gas lucency here. And then again, we're not looking at the fetlock on this image, but you can see here maybe there's a little something going on there off that sesamoid bone, and maybe this is what we're seeing on that lateral projection. Excuse me, a little fragmentation of that lateral suspensory branch. Again, nothing on flexion of that fetlock, nothing on palpation of that branch. It didn't even palpate thicken, certainly not palpate sore. So at that point, that in my opinion is an old injury that might be related to what we're going to get into, but not our current issue. I did ultrasound that right front proximal suspensories, even though we were positive to an abaxial. That was the most significant finding on palpation and clinical exam. So these are all non-weight bearing images, and we can see that we do have some irregularity in our palmar cortex here laterally. We do have some asymmetry as far as enlargement of this lateral lobe versus this medial lobe. And we can see a pretty nice distinction in our architecture between our more fatty bundles and our more muscular bundles and tendinous bundle here on the medial lobe, but we lose that architecture pretty much completely on this lateral lobe. Similar view here, some irregularity in that palmar cortex, and some irregularity in asymmetry in the size and irregularity in the echogenicity or architecture of that structure. Couple more images here. Longitudinal, we can see some irregularity in that palmar cortex here as well. Fiber pattern, the alignment of this image isn't great, so I wouldn't use that too much to try to assess linear fiber pattern. Plus, I did this one non-weight bearing, so you're gonna have relaxation artifact in that anyways. This was mostly just to get a good representative view of this palmar cortex. Then I included this image in here as well. So again, this is a non-weight bearing proximal suspensory view. Same things that we were talking about on this lateral branch here. Then again, non-weight bearing, so we're going to have some artifact, but I did think that this part of the check ligament or the accessory ligament of the deep digital flexor tendon was a little bit irregular as well. So that kind of gets into what we were talking about, all these structures being really closely associated and having similar insertions and similar functions and similar sensitivity to injury. Right, this accessory ligament of the deep digital flexor tendon also has origins in that palmar carpal ligament, just like some of the contributions of the fibers of the suspensory ligament. And they can both get injured with fetlock hyperextension, with carpal hyperextension. All of those things have similar effects on these structures. So that's just something to note. It was not our main finding, but something that we did take into account. Took some radiographs of this knee, especially with the irregularity on that palmar cortex. I like to kind of see what those look like on radiographs, see if there's any associated carpal arthritis or if there's any obvious enthesopathies we can see. So on this DP projection, we can see that there's a little bit of sclerosis here, and that likely correlates with what we're seeing with this palmar cortical, specifically lateral palmar cortical remodeling here on ultrasound. So, kind of a subtle finding, but I do like to look at these when we're looking at enthesopathies of the proximal suspensory ligament. Lateral projection, really not that exciting. Maybe there's a little bit of sclerosis here on the palmar cortex, but that's pretty subjective. So, kind of synthesis summary of findings on this horse: proximal suspensory ligament desmitis and enthesopathy, chronic lateral suspensory branch desmitis and enthesopathy. So those are the incidental findings that we're seeing on that. On those radiographs that we took for the feet. I did scan that branch. The branch itself had some mild remodeling, some mild scar tissue, but that looked pretty pretty old and pretty quiet. And then we also had that gas opacity at the heel bulbs. So suspicious of an abscess there. We did block to an abaxial, even though we didn't have any sensitivity on hoof testers. There's definitely still something going on in that foot. Treatment at this point was poultice the right front foot, trying to get that abscess, if that is indeed what that is, to resolve. Treatment with osphos for the enthesopathy aspect, both at the sesamoid and at the proximal suspensory. And then we did some shockwave, that should say right front proximal suspensory. Start on my Adequan, and then I believe Dr. Burnham was doing some chiropractic work with him as well. This was recheck the following day. I didn't have time to do a direct proximal block on him that day, so luckily the client was willing to bring it back the next day. Because I was, even with the blocking pattern, the abscess and everything else, I was fairly certain that a decent amount of that lameness was coming from that proximal suspensory ligament. So just a quick baseline for us again. If anything, we're even a little bit worse than we were yesterday. Not that surprising. Yep. And then this is right around 5 minutes after a direct proximal suspensory ligament block. So low volume, ultrasound guidance, so pretty darn specific as far as the actual blocking goes. And I think we have as much, if not more, improvement from this block than we did the abaxial following day. So that's all we did on him that day. I just wanted to confirm that we were dealing with an active proximal suspensory ligament there. I'm going to speed through some of this. This isn't terribly important. That abscess ended up getting worse, and he was 4 out of 5 lane. So this was a few days after the block. Client calls me. Not what you want to see. But it happens. Luckily, it was just that abscess had kind of matured. We can see on these images here, big old medial heel bulb abscess. We're able to get that resolved. And about 20 some odd days later, brought him back. Yep, pretty good there. So again, this is just a few weeks of rest, Adequan and some shockwave on that proximal suspensory, as well as resolution of that abscess, which obviously was contributing some portion of that to that lameness. So there's a Churchill on that one. Yep, positive, but really not terrible. His horse was still incredibly sensitive to palpation. There's still quite a bit of heat on that proximal suspensory ligament. So we went ahead and treated that to put some Renovo in there.